USMLE Step 1 will also require from you to have some ideas as to how clinical trials are conducted. After all of us, when we do rotations in the hospital, end up encountering some primary investigators involved in clinical trials, and most often during those rotations we end up being enslaved, literally, as you probably know, in running part of the clinical trials. Hopefully that lands you a poster or a publication that then you can use on your CV. Overall though, what does the exam want you to know? Well, they want you to have an idea, exactly as shown in the syllabus, as to what are the phases of clinical testing, and particularly what kind of question are you trying to answer, and by what means will you achieve those answers in doing those different phases. Clinical testing of drugs always follows first extensive preclinical studies done by the drug companies and university researchers. Clinical testing can only come after having proven that a drug may have an effect either on cell cultures, on animal models, and so forth, and has shown significant safety, particularly in those type of protocols. If preclinical testing is deemed as being really promising, then FDA may allow the actual investigational new drug to undergo a clinical trial. Well, the first phase of a clinical trial, phase 1, is going to answer whether the drug is safe or not in a human population. Now, to answer whether a drug is safe or not, simply you're going to find a group of humans who are ready to receive a drug that's never been tried in humans before. Who are they? They are not patients. They tend to be healthy volunteers. And the most classic healthy volunteer in hospital, a medical student. Generally, you give that medical student a few bucks or a free lunch, and most often you'll have someone who will undergo a phase 1 clinical testing. Now, keep in mind that the drug that will be used has been extensively studied before, so that hopefully that medical student won't drop dead. But overall, in that small group of volunteers, what you will have to do to answer that question is an escalation paradigm. That is, giving the drug at higher and higher doses until that group of students will start complaining of side effects. Essentially, know what you're getting into when you're going into a phase 1 clinical trial. Certainly, the doses that will be tried on that healthy volunteer population are the doses that are planned to be used for therapeutic purposes. So imagine you've given that drug, you've given the entire range of doses you plan on using in a patient, maybe even a little beyond in case someone would take an overdose or have poor renal function and so forth in your real life scenario down the road, and none of your healthy volunteers complained of drastic side effect. You know, you always find someone who maybe had a little insomnia, who maybe felt a little depressed or had a little diarrhea or something like this, but nothing life-threatening. Package all this data, send to FDA, tell them this is the data of my phase 1 clinical trial, it's safe, can I now do phase 2? And hopefully FDA will tell you, yes, go ahead into phase 2. Phase 2 is answering what we are very much trying to figure out: does the drug work? And now to see whether the drug works, now that you've established it is safe in healthy volunteers, there's no two ways. This time you will need to have access to a patient population. A phase 2 clinical trial will take a small number of patients, a couple dozens of patients maybe. And to prove to yourself whether the drug works or not, you will need to compare that drug to something else. You know, the best case scenario would be to compare your drug to what we call a placebo. A placebo is simply a sugar pill. Surely, if you hope your drug to have any effect, compared to someone who takes a sugar pill, it should be fairly easy to show that effect. But now think of the ethics of this. Think of taking a group of patients and say, well, in that group I'm going to give my new drug which works on cancer. In that other group, I'm going to give them a sugar pill. Too bad they have cancer, they'll die from it, and surely my drug will show a great effect compared to the sugar pill. Most often, as you realize in my exaggerated example here, to answer whether the drug works or not will not be done against a placebo. It will be done against what we call a positive control. A positive control is a drug that is currently established, FDA approved, for use in the disease for which your new drug is planned to be prescribed. And in doing so, it becomes much tougher, of course, to show a great deal of effect or a great deal of benefits in putting on the market a new drug. Now, this is a way also of protecting the general public from drugs that may not be that efficacious after all. We have a second point to bring up that is board relevant. When you do does it work, not only you do a comparison against a positive control or if you're lucky a placebo, but you also have the issue of the psychology of drug prescription. You know that the presentation of a drug is just about 50% of its effect in a patient. If you present a drug with a great deal of emphasis on how good it's going to be and how well it's going to work and how you believe it's going to be really a miracle cure, guarantee the patients are going to find an effect. If you present your placebo, on the other hand, as well, you know, all you're taking is a sugar pill, so probably nothing will happen, then surely nothing will happen. So then comes the issue of blindness in clinical trial. We talk about single versus double blind in the syllabus. In all cases, the patient is blind to the drug they're receiving. Being single blind means the patient has no idea whether he or she is receiving a placebo or the actual drug, or a positive control and the actual investigational drug. But the doctor who's prescribing it knows. Therefore, the doctor could still impart some psychology to the drug that is given to that group of patients. This is why what is favored most often by FDA and the general research world is what we call double-blind studies. A double-blind study keeps both the prescriber and the patient population in the dark as to whether they're giving or receiving the placebo, positive control, or the actual investigational drug. Now imagine you did your phase 2 trials in a hospital. You had a group of, let's say, 60 patients, and you showed some great effect. Now your big issue is really over 60 patients. Probably you have not seen that many side effects. Plus, you don't know if there was something very special based on your inclusion criteria in that group. Maybe if you were doing in more than 60, the effect would not be so good, or maybe some side effects may pop up. So then FDA, most likely following a phase 2, will allow you to enter a phase 3 clinical trial, where you will answer whether the drug still works when you're in larger populations. Maybe you're dealing with several hospital centers across the country, or maybe in different countries. And by using a much larger sample of patient population, you'll be able to assess the common side effects of the medication. Essentially, this will be done again against controls, either placebo or positive control, and generally again in double blind. At the end of phase 3, if all went fine, the drug can now be placed on the market. Meaning the drug is now going to be available to any prescribing authority out there to be used in patients. Now, does it mean the clinical trial is over? The answer to this is absolutely not. Now comes the toughest section of a clinical trial, called a phase 4. The phase 4 is really the post-marketing surveillance. Sometimes it's referred to as pharmacovigilance. Understand, when you were building the clinical trial in hospitals, you were dealing with some very selective patients. You know, for instance, you had taken patients all of the same ages, maybe all of the same sex, maybe all of the same ethnic origins. Certainly, you had patients with a certain disease and often no other comorbid condition. Now that your drug is marketed and used worldwide potentially, that drug is now going to go into people of all kind of ages, all kind of ethnic groups, and potentially different genders. Add to this, these same drugs will now be in patients who may suffer other diseases, maybe take other drugs at the same time. And it is most important to then be vigilant and look at what happens once the drug is in general population. That's the role of a phase 4. On your exam, I know of one question about this. And the question pretty much asks you as to when is it more likely that a drug is withdrawn from the market. Phase 1, phase 2, phase 3, phase 4. Well, guess which phase is the one that is more likely associated with withdrawal of a drug? It is the post-marketing phase that we call phase 4. A classic example lately, think of drugs like celecoxib, rofecoxib, the famous cyclooxygenase 1B inhibitors. And those drugs have only been seen later on once in the general population as being associated with significant cardiovascular toxicities, which have warranted those toxicities, the removal, the withdrawal from the market of some of the prototypes of that class group of anti-inflammatory drugs. Final point, still dealing with FDA and dealing with potential problems with drugs as they come on the market. The problem of teratogenicity. What do we do with drugs and pregnancy? Well, there the issue is really confounding from the standpoint that trying to have studies assessing the teratogenicity of drug is going to be very troublesome. Imagine at the ethical level, you cannot possibly decide that you're going to carry out a study of pregnant women and the effect of the drug on the fetus. So that often the data is anecdotal. Now, we do have pregnant animal studies, and the table shows you that FDA classifies drug in a system of letters based on the teratogenicity potential. For your exam, realize that a class A drug is a drug for which there have been pregnant human studies and pregnant animal studies done, and in both cases the minus sign in the table means those studies showed no teratogenicity. If the studies are there and the teratogenicity potential is therefore nil, nothing, no teratogenic potential, then a drug is called a class A. This is very unusual. But some classic example, I would focus on folate. That actually folate, we like to supplement it upwards of 3 months prior to pregnancy to prevent neural tube defects in the baby. So folic acid would be a great example of a class A drug. Go to the end of the table now and look at a class X. A class X is a drug that has known human studies and known animal studies where teratogenicity has occurred. In that situation, a class X is absolutely contraindicated in pregnancy. You can see that a great example of this, any steroid type of drugs, such as oral contraception, such as clomiphene, such as drugs that work on prostaglandin like misoprostol, all of those, would be significantly teratogenic or promote abortion. A great vitamin, if you wanted to contrast to folate, vitamin A, lipid-soluble vitamin, absolutely contraindicated because of teratogenicity. If you suffer from acne and you want to use vitamin A derivatives, a contraindication will always be pregnancy. So where are most of our drugs? A or X? Well, actually, most of our drugs we prescribe are neither A nor X. They really sit somewhere in the middle. And what the table shows you with 0, minus, or plus signs is pretty much the story of most of the drugs of the PDR. When you see 0, it means the absence of studies, so we can't conclude. When you see a minus, studies have been done and have shown the absence of teratogenic potential. And when you see a plus, studies have been done and have shown teratogenicity. For instance, a class B drug is a class of drug where pregnant animal studies have been done and either showed no teratogenicity or showed some, but studies in pregnant humans are lacking or are conflicting with the pregnant animal studies. What should we do then? Well, really, we try and avoid them during pregnancy if we can, but sometimes we may benefit from such drugs. The example given to you in the table is AZT. AZT is an antiviral drug used in HIV patients, and it so happens that although we're not quite sure about the teratogenicity of AZT in most studies, the fact is AZT decreases vertical transmission from HIV mom to her child by over 80%. So that irrespective there of the actual finding, AZT would always be considered a great drug to give during pregnancy. Notice a drug like aspirin. Aspirin is a class C drug. The vast majority of the drugs in the PDR are class C drugs. These are drugs where basically there are no human studies available. So it's up to us to decide whether yes or no it's worth taking that drug during pregnancy. Yet you see that in some instances there might be some animal data showing that teratogenicity. So an interesting class is class D. A Class D drug, notice, just like a Class X, is associated with studies both in humans and in animals showing teratogenicity. So why are they not called Class X? Well, because those deal with drugs that could be life-saving to the baby or to the mother, and therefore whereby maybe the teratogenicity being a risk is not going to be an issue. There could also be drugs that could be used at certain points in the pregnancy term. You know, not all drugs are going to be teratogenic over 9 months of pregnancy. Often the teratogenicity is very time specific, so that if we avoid that time, then the benefit on being on such a drug for the rest of the pregnancy would be really instrumental. Example, an ACE inhibitor. Although ACE inhibitors are contraindicated in the general management of hypertension in a patient who's pregnant, really, they are to be avoided mainly in the first trimester. And in a pregnant lady who would suffer from eclampsia, whereby the hypertension, the seizures could be life-threatening for the baby, an ACE inhibitor would be absolutely indicated, since eclampsia would declare itself much later on in pregnancy. Same story with anticonvulsants. Although they're known teratogenic, it is still much more life-threatening to have a pregnant lady suffering from seizures than having that lady on anticonvulsants. You know, when these things happen, how do you choose the best drugs to use in pregnancy? We saw this a few tapes ago. You remember the protein binding? The higher the protein binding, the lesser the free fraction, the lesser the likelihood of some of the drug reaching fetal circulation and reaching the baby in utero. That could very well become the rationale behind choosing the best drug in the class considered for therapy. This concludes our general principles section. Our next sections in the syllabus deal with conventional pharmacology. That is, looking at drugs, looking at which receptor they bind to, and deriving from our knowledge of physio in particular, but also biochemistry, very much what we expect these drugs to do. We'll start this with the autonomic nervous system chapter.